Welcome to the University of Kentucky Department of Anesthesiology's YouTube channel. The following presentation is part of our high-yield keyword review, this one on respiratory anatomy, physiology, and thoracic anesthesia, and it happens to be part one of a five-part series. As a reminder, keywords are published by the American Board of Anesthesia each year after the in-training exam and represent the key concepts around which a question was developed. Throughout this slide set, those that are in purple represent the most recent in-training exam keywords from 2019. These are the keywords broken down into the categories of anatomy, physiology, pharmacology, clinical pathophysiology. For example, airway innervation, the B after it stands for basic anesthesia content. Mallampati airway classification, again, basic content. Difficult mask ventilation, what are the predictors? And under physiology, things like airway resistance and gas density and alveolar gas equation. What happens when you intubate a bronchus rather than the trachea? Hypoxic pulmonary vasoconstriction and the things that inhibit it. The pharmacology of the airway, specifically focusing on drugs that block IgE and leukotrienes. And then some clinical and pathophysiologic concepts, including complications of bronchial blockers, epidural anesthesia and its respiratory effects, laryngospasm, arterial blood gas values, which are measured versus which are calculated. The A after this stands for the advanced anesthesia content. Acromegaly and how an airway can be difficult to manage in those patients. Myasthenia gravis and how some of them require postoperative ventilation and what predicts that. Pulmonary hypertension, the causes, transfusion-associated lung injury, risk factors for such, airway fires, and capnothorax. Respiratory keywords represent about 10% of all the IT keywords, and this five-part series will cover over the last about 12 years of keywords. Just for example, in 2018, you can see similar keywords like laryngoscopic view, cricoid pressure, oxyhemoglobin dissociation curve, respiratory effects of TPN, what happens at high altitude, to the physiologic changes in the respiratory system, bronchoconstriction and the pathway of such, how to measure lung compliance, the effect of obesity and aging on pulmonary factors and physiology, upper respiratory tract infections and airway reactivity, respiratory failure, difficult airway algorithm, hyperbaric oxygen, bronchial blockers and double lumen tubes, jet ventilation, airway fires, negative pressure pulmonary edema, the effects of laparoscopy on the respiratory system, ventilator-acquired pneumonia, or VAP, and subglottic drainage endotracheal tubes, indications, and near-drowning management. Those were from 2018. And on 2018, there was a gap in knowledge where more than 50% of those taking the exam missed the question related to the fact that ACE inhibitors, when you start them in a patient, in some patients can cause airway edema where emergent airway management is required, and we'll cover that. In 2017, these are the key words. Again, many of the similar concepts that you can see. There was a gap in knowledge in 2017 that the posterior cricoarytenoid muscle is solely responsible for pulling the vocal cords apart and are attached between the posterior cricoid cartilage and the arytenoid cartilages bilaterally, and we'll look at that. So keywords will guide the next five-part series, and this is again part one of this five-part series. We'll begin right with airway innervation, and it being in purple represents the fact that it was a keyword in 2019. Cranial nerve 5, 9, and 10 innervate the airway. And up at the top right in light blue represents cranial nerve number 5's distribution, the nares and the nasopharynx. In yellow represents the glossopharyngeal or ninth cranial nerve, the tongue and oropharynx, and the upper epiglottis, and the gag reflex, such that if someone had a very hyperactive gag reflex, cranial nerve number 9 would be the one that you would want to make sure that you adequately anesthetize, either topically or possibly and rarely with a nerve block of the glossopharyngeal nerve at the base of the tongue next to the tonsillar pillars. In reddish pink represents the 10th cranial nerve, a very important nerve for a large part of the innervation of the airway, both of the sensory distribution as well as the muscles that are responsible for vocalization. So let's follow cranial nerve number 10 now, which is innervation of the upper, or that is innervation of the epiglottis, the lower part of it, and everything below it, the glottic structures and the trachea, and we'll follow cranial nerve 10 down. So in the bottom right is a picture of the nerve distribution of the cranial nerve 10. It represented in blue. Let's follow, first of all, the superior laryngeal nerve in yellow as it comes down, and the first branch in orange is the internal branch, which pierces the thyroid, the membrane between the thyroid cartilage and the hyoid cartilage, the thyrohyoid cartilage, and when it pierces it, it goes in and provides sensation above the vocal cords. Internal branch, sensory above the vocal cords. Now if we follow the orange branch of the superior laryngeal nerve farther, this is the external branch, and it's motor to the cricothyroid, which is a tensor of the vocal cords. It is the one muscle that's not supplied by the recurrent laryngeal nerve. The superior laryngeal nerve can be blocked at the thyrohyoid membrane bilaterally. More commonly, simple spray and go or topicalization of the distribution of this nerve is performed. Now the recurrent laryngeal nerve is represented as a branch of the vagus in green in the bottom right. The recurrent laryngeal nerve is sensory below the glottis and encompasses the innervation of the trachea and is motor to all the muscles of the larynx except that one tensor, the cricothyroid, which was supplied by the external branch of the superior laryngeal nerve. The recurrent laryngeal nerve can be blocked by a transcricothyroid injection of local anesthesia into the trachea. The patient coughs and it distributes it up and down the airway. Damage to the recurrent laryngeal nerve, if it's unilateral, voice changes and hoarseness can occur, and if it's bilateral, aphonia and even complete airway obstruction can occur. The injury to the recurrent laryngeal nerve, if it's bilateral, can result in adducted vocal cords, that is, closed vocal cords with acute obstruction, such that emergent airway management may be required, such as reintubation or even tracheostomy. If complete transection of the recurrent laryngeal nerve occurs, the vocal cords remain paralyzed in a paramedian position, almost like curtains floating in the air as air moves in and out of the glottic opening. Let's look at laryngeal anatomy in a little bit more detail here. At the top right is a picture of the vocal cords, true vocal cords in white. Next to them, the false vocal cords, the epiglottis up on top, the arytenoids in the bottom here, the piriform fossa on each side, that piriform fossa being the place where often our nasogastric and oral gastric tube gets caught. Our fiber optic scope sometimes ends up in there, and we can see the light in the lateral aspect of the neck when it's not midline. On the left represents the larynx in adduction or closed, and on the right represents the larynx in abduction or open. Now the recurrent laryngeal nerve supplies all the muscles of the larynx except that one tensor of the vocal cords, the cricothyroid, which was supplied by the superior laryngeal nerve external branch. Abduction, or pulling apart of the vocal cords, is accomplished by the posterior cricoarytenoid. And on the bottom right, you can see that little muscle, the posterior cricoarytenoid, when it contracts, pivots the cartilage and pulls the vocal cords apart. Abduction. This was a gap in knowledge in 2017 on the ABA in training examination. Adduction, or closing of the vocal cords, is the lateral cricoarytenoid. And in the picture at the bottom right, you can see when that muscle contracts, it pivots the little cartilage and closes the vocal cords. The next key word is airway examination and grading of the airway. When you do a mallampati assessment, you have the patient sit up, lean forward, not vocalize, open their mouth wide, and you look in the back of their mouth and try to determine, can I see the hard palate, the soft palate, the uvula, the tonsillar pillars? And the more you see, the more assured you are that the grade view when you do laryngoscopy is going to be easier. That is, your hope is that you'll be a grade 1 view and see everything. Potentially not a grade 4 view where you cannot see anything, and a grade 3 view where you may have a difficult intubation when you can only see the epiglottis. But back to the mallampati examination, if you can only see the soft palate, part of the soft palate and the hard palate, we have a class 3 mallampati examination. If you can only see the hard palate, it's class 4, and if you can see everything, it's class 1. The components of the preoperative airway physical examination are many. We can look at their upper incisors, their teeth, how long they are, whether they have a prominent overbite, whether they can protrude their mandible and put their bottom teeth over their top teeth. When they open their mouth, what's the inner incisor distance, and it should be greater than 3 centimeters. If we can see the uvula, we feel better about the mallampati classification and the potential for ease of grade of laryngoscopy. The thyromental distance, if we can get 3 finger breaths in there, or if it's greater than 6 to 7 centimeters, we say, that's a normal thyromental distance. And if it's less than that, we say that's a potential predictor, at least one variable for predicting a difficult airway. And then last, thickness of the neck and range of motion of the neck and head are things we evaluate. Cricoid pressure, often applied during a rapid sequence induction. There's some controversy about it because when you apply cricoid pressure, it decreases the lower esophageal sphincter tone. And if lower esophageal sphincter tone is decreased, there's a potential risk at least for regurgitation of the stomach contents. Cricoid pressure, especially if it's applied improperly, can obscure laryngoscopic view and make it harder to see the glottic opening. It can make bag mask ventilation more difficult and laryngeal mask airway placement more difficult. And if someone's actively vomiting or there's unstable cervical spine, it's contraindicated. Thyroid pressure up on the thyroid cartilage is applied during the back up to the right pressure maneuver that we often do, reach around to try to improve our laryngoscopic view. So thyroid pressure to try to improve our laryngoscopic view is something that we can do. Difficult airway algorithm is the next key word. Let's define difficult mask ventilation first. The ASA difficult airway algorithm is shown to the far right, and the explanation of what a difficult mask ventilation is defined by the inability of an unassisted anesthesiologist, one person who's trying to ventilate someone, to maintain their saturation greater than 92% or prevent or reverse signs of inadequate ventilation. The CO2 is rising, end-tidal CO2 is rising, the saturation's dropping, you're by yourself, you're having difficulty ventilate that patient. And the predictors of difficult mask ventilation include things like a beard, BMI, body mass index greater than 26, when they don't have their teeth, and a history of snoring, which often is associated with obstructive sleep apnea. Difficult endotracheal intubation is defined by when you've taken more than 3 attempts at intubating a patient and you've been unsuccessful, or it's taken more than 10 minutes. The airway algorithm at the far right suggests that we should consider a supraglottic airway, like a laryngeal mask airway, when we cannot intubate and cannot ventilate. So we're struggling with ventilation, we can't intubate. More than about 95% of the time we can place a laryngeal mask airway and convert that to a can ventilate situation. Now, if we have placed or attempt to place a laryngeal mask airway and it's not working, we cannot ventilate, we cannot intubate, at that point an invasive airway like a cricothyrotomy is indicated, and in the cannot intubate or ventilate scenario, and that's shown at the bottom right red arrow in the ASA difficult airway algorithm. The next keyword is actually a gap in knowledge from 2018 in training exam, that ACE inhibitors can cause facial and airway edema and make airway management very difficult because they are associated with angioedema. So ACE inhibitors like lisinopril, when they're started in a patient, can induce swelling of the airway and the face. And the graphic on the far right and the top right are examples of why this happens. The top right shows a patient with a swollen tongue and airway after an ACE inhibitor had been started in them. The ACE inhibitors inhibit the breakdown of angiotensin 1 to angiotensin 2, the formation of angiotensin 2, and are contributors to why they're effective as an antihypertensive agent. But also, we often forget that ACE inhibitors block the breakdown of bradykinin to an inactive metabolite. So if bradykinin is sitting around, it causes vasodilation and is one of the major reasons why ACE inhibitors cause a decrease in blood pressure. Now, bradykinin is also the explanation for why they have problems with cough sometimes, and what we're focusing on here, which is the angioedema of the airway. It rapidly develops, often after the first dose, and is more common in African Americans. This increased bradykinin, as pointed out, is associated with the vasodilation, which is part of the expected effect from starting an ACE inhibitor, but angioedema and cough are complications related to buildup of that bradykinin. In the case of ACE inhibitor angioedema in emergent intubation, wake fiber optic intubation often is indicated, or possibly even a surgical airway may be required. The next key word is airway anesthesia, how we can accomplish such. The top left shows a superior laryngeal nerve block internal. Internal meaning that you can take a Krauss forceps or some other forceps, soak some gauze with local anesthesia and hold it back there along the side of the epiglottis, and you would anesthetize the distribution of the superior laryngeal nerve internally. Now this is rarely done because spraying a local anesthetic on the back of the posterior pharynx will anesthetize this quite satisfactory usually. Now a superior laryngeal nerve block can be also performed externally with a needle bilaterally injecting local anesthetic at the location where the internal branches of the superior laryngeal nerve enters the thyrohyoid membrane. It pierces it. Remember that the internal branch supplies sensation of part of the epiglottis, upper airway. This is somewhat of a painful block, and again, we rarely do this external block of the superior laryngeal nerve. The glossopharyngeal nerve, or ninth cranial nerve, can be blocked at the base of the tongue, next to the tonsillar pillar in the gutter here, where the needle can enter and inject local anesthesia, and the gag reflex would be blocked fairly effectively. Again, just spraying as you go, often with a local anesthetic, adequately topicalizes the distribution of the glossopharyngeal nerve. Transtracheal anesthesia, or taking a needle, putting it through the cricothyroid membrane and injecting local anesthesia into the trachea. The patient coughs and distributes it up and down the trachea, can anesthetize the distribution of the recurrent laryngeal nerve, its sensory distribution, that is. Airway anesthesia, if you're going to topicalize someone, make sure that they're dry. Glycopyrrolate's quite effective at drying the airway, given at least 15 minutes or so before you begin topicalization. There's many options for airway anesthesia. Spraying lidocaine in the airway, often in a nebulizer. As someone breathes the nebulized lidocaine and takes deep breaths, it can be quite effective in anesthetizing the whole airway. You can take local anesthetic spray like benzocaine or lidocaine and spray the anterior mouth, the tongue, and the oral pharynx. Have them take a deep breath as you spray, and if it goes down below the vocal cords, can block the recurrent laryngeal nerve sensory distribution. You also may use a transcricothyroid injection of local anesthesia to help get that recurrent laryngeal nerve distribution. Remember that if you spray the local anesthesia repetitively and in large doses, benzocaine is associated with methemoglobinemia. It is oxidation of the iron in hemoglobin from Fe+2 to Fe+3, and the SpO2 saturation monitor heading towards 85%, where methemoglobinemia, the methemoglobin, that is, has a absorption spectra. So benzocaine is a risk for methemoglobinemia. We can spray the local anesthesia in the anterior mouth and oral pharynx. You could do a glossopharyngeal nerve block, either with a needle or with gauze soaked and held in the tonsillar pillars. the superior laryngeal nerve block at the thyrohyoid membrane, and a recurrent laryngeal nerve block, as we talked about, by a transcricothyroid injection of local anesthesia. Multiple options for airway anesthesia. The next key word is innervation of the airways. Again, it's in purple because in 2019 it was an in-training exam key word. Innervation of the airways and regulation of airway caliber. Let's focus on the picture at the far right first. In light blue represents the vagus nerve, and it predominates in innervation of the airway. In reddish pink represents the sympathetic nerve innervation, which is sparsely innervating the airway. And then in green represents motor to skeletal muscle, for example, the phrenic nerve coming down from C3, 4, and 5, innervating the diaphragm, and the intercostals coming over and innervating the intercostal muscles, which are associated with respiration. Let's focus on the parasympathetics first. There's rich innervation of the bronchi and bronchioles via that vagus nerve represented in light blue. The vagus nerve releases acetylcholine onto muscarinic receptors, and when that occurs, bronchoconstriction results. Ipratropium is an inhaled anticholinergic, which is fairly effective at blocking bronchoconstriction. The sympathetics, there is sparse innervation of sympathetic nerves to the airways, but circulating catecholamines can have a major effect. That is from your adrenal, or if you administer them exogenously, like intravenous epinephrine, because beta-2 receptors are present in high concentrations in the peripheral lung, and when they're activated, bronchodilation occurs. Albuterol inhaled or intravenous epinephrine via the beta-2 receptor results in increased intracellular cyclic AMP and bronchodilation. Histamine can cause bronchoconstriction via stimulation of the H1 receptor, and this is the predominant effect of histamine. So an allergic reaction with release of histamine can result in bronchoconstriction. Interestingly, the H2 receptor, when it's stimulated, results in bronchodilation. Therefore, the worry that if you start an asthmatic patient on an H2 blocker, you might have bronchoconstriction occurring. The major point of this is that the parasympathetics richly innervate the airways of the respiratory system. Airway pharmacology, let's talk about bronchodilators. First, beta-2 agonists. There are short-acting beta agonists, and we use those usually for rescue medications, albuterol being an example. And then there's long-acting beta agonists that are used to control asthmatic or bronchoconstrictive symptoms. Salmeterol is an example of one of those long-acting beta agonists. Those long-acting ones are not to be used in acute asthma, and you're not to use the rescue medications, the ones that are short-acting, repetitively, because if you use the short-acting ones multiple times a day, when you really need them, you may be tolerant to their effects, and an asthmatic attack may become very bad and unresponsive to the albuterol. So it's used to rescue an asthmatic bronchoconstrictive event. Now, steroids are often combined with long-acting beta-2 agonists. Fluticasone and salmeterol equals Advair, that combination of such. Tolerance can develop to beta agonists because the beta receptors downregulate. Side effects of beta-2 agonists include tachycardia and driving potassium into the cell, hypokalemia. In fact, beta agonist inhaled, such as albuterol, is one of the treatments for acute hyperkalemia. Muscarinic antagonists can be used as bronchodilators. Inhaled anticholinergics like ipratropium. Ipratropium plus albuterol in combination is Combivent, and tiotropium is a long-acting anticholinergic. They are especially useful, these anticholinergics, for patients with emphysema and bronchitis. They tend to have a slower onset than the beta agonists, and they tend not to increase the heart rate like the beta agonists. They may be best for treating bronchospasm with tracheal instrumentation, which tends to be muscarinic mediated. So if you're putting things in the airway, these anticholinergics are pretty effective at blocking the bronchoconstriction that's associated with that. IV anticholinergic is glycopyrrolate. And other bronchodilators like methylxanthines, which is a phosphodiesterase inhibition, theophylline being the example, aren't used much anymore. Anti-inflammatory agents are used in asthma and allergies. Mast cell degranulation inhibitors like cromolyn, rarely used today. Corticosteroids, commonly used both inhaled, things like fluticasone or Flovent, or orally like prednisone. Leokotriene inhibitors, drugs that block the receptor like montelukast or Singulair, and 5-lipoxygenase inhibitor like xyluton or Zyflo. These are leukotriene inhibitors trying to get at the inflammatory component of asthma. And then there's newer IgE inhibitors. Xolair is an example of that. And any drug that ends in MAB, we think of it being an antibody. And Xolair is an anti-IgE monoclonal antibody that actually binds and captures circulating IgE and prevents the interaction of IgE with the receptors on mast cells and basophils. It tends to be used in patients that have pretty bad asthma to allergens when their allergic asthmatic reactions are inadequately controlled with inhaled corticosteroids. You would add an Ig inhibitor like Xolair. Respiratory effects of inhaled anesthetics is the next keyword. That is, what do volatile anesthetics do to the respiratory system? Well, first of all, the pattern is one of a low tidal volume and increased respiratory rate or panting. Not infrequently, the tidal volume, which maybe normally is about 450 mils, will drop down to 200 to 250 mils or so, and the respiratory rate will go up into the 20s. Classic example is someone breathing sevoflurane through a laryngeal mask airway with a tidal volume of 250, an end tidal CO2 of 50 or 55, and a respiratory rate of 25. Now, alveolar minute ventilation is decreased. Why? Because the tidal volume goes down and dead space stays the same. Dead space is about 1 mil per pound or 2 mils per kilogram, or approximately 150 mils, just to get air down the trachea to the terminal bronchioles where air exchange starts. So if dead space is 150 mils and your tidal volume is only 300 mils, the ratio of dead space to tidal volume is about 50%. So more and more goes to dead space relatively when your tidal volume is low. Airway resistance is decreased by all the inhaled volatile anesthetics. They're all bronchodilators. And the ventilatory response to hypercarbia and hypoxia is greatly affected, especially to hypoxia. Now, if you became hypoxic, you should hyperventilate. But if you have inhaled volatile anesthetics on board, that is greatly depressed. And in fact, at greater than about a MAC or so, it's 100% depressed. And even at sub-MAC concentrations like 0.2 MAC will decrease the hypoxic response. So you could have a patient in the recovery room awake with sub-MAC concentrations of a volatile anesthetic and their hypoxic response being blunted. It takes a little bit more to block the CO2 response. That is, as CO2 goes up, you should hyperventilate, and if a volatile anesthetic is on board, this will be blocked. So our volatile anesthetics are blocking the central and peripheral chemoreceptor function in a dose-dependent manner. Respiratory effects of neuraxial and intravenous anesthetics is the next keyword. Respiratory effects of epidural anesthesia was an ITE keyword in 2019. Let's focus first on spinal and epidural anesthesia and what they do to respiratory mechanics. There's little effect on pulmonary function, things like tidal volume, respiratory rate, minute ventilation, response to carbon dioxide, except the ability to cough effectively. If you've blocked the intercostals, you have very high dermatomal levels, the cough may be affected. And in a bad COPD patient who has a lot of mucus, this may be a problem. They may not be able to bring up that mucus. If you have high thoracic levels and the intercostals are blocked, patients will often complain of dyspnea. I just can't feel myself breathing. It feels weird. They feel like they have chest tightness. They have lost afferentation from the intercostals and they just don't sense or feel that they're breathing. Cervical levels can impair diaphragmatic function. Remember the phrenic nerve, C3, 4, and 5. If you were way up at that level, you'd be in real problem as the phrenic nerve becomes blocked, diaphragm is out, intercostals are out, and you would have to be ventilating that patient. Respiratory arrest can occur with spinal and epidural anesthesia, with high levels especially, but it doesn't just have to be a high level blocking way up in the cervical dermatomes. If you get really bad hypoperfusion, hypotension, if the blood pressure drops very low, the respiratory centers can be hypoperfused, and that can be the cause of the respiratory arrest rather than blocking the dermatomal levels way up at the cervical level. IV anesthetics and their respiratory effects, dexmedetomidine or Precedex has very little effect on respiratory mechanics or gas exchange, and often used for sedation in the intensive care unit. Ketamine, no significant depression of ventilation when it's used alone. When it's used in combination with opioids or benzodiazepines, it can have depression. It tends to maintain the upper airway reflexes. Anyone who's tried to intubate someone with ketamine alone knows that, while propofol is very effective at blocking the upper airway reflexes. Ketamine's a bronchodilator, but it increases salivation through its sympathetic cholinergic activation, and we tend to block those increased salivation when we use ketamine with a drug like glycopyrrolate. Propofol causes apnea in induction doses. It decreases tidal volume, increases the respiratory rate, so it's blocking respirations. It blunts the response to hypoxia and hypercarbia, and is a bronchodilator thought to be due to its effect on intercellular calcium. The next key word is control of breathing, and we'll look at the graphic on the far right first. Up at the brain level, we can voluntarily control our breathing. We can say, I'm going to increase my respiratory rate and start breathing faster. Emotional stimuli can act through the limbic system and affect our respirations. There's receptors for touch, temperature, and pain. If we have a pain receptor activation, we may start breathing faster. But we're going to focus in on the two main ones represented by the red stars, the top left one being a star next to the peripheral chemoreceptor at the carotid, which responds to PaO2, P-little-a-O2, the partial pressure of oxygen, and the red star at the brainstem, where the central chemoreceptors in the medulla, which respond to changes in carbon dioxide that crosses the blood-brain barrier and changes the hydrogen ion concentration at the brainstem and results in changes in ventilation. So let's focus on the central chemoreceptor first in the medulla. It responds to changes in carbon dioxide. As your CO2 builds up, it crosses the blood-brain barrier, raises the hydrogen ion concentration about that respiratory center, and respiratory drive increases. In a COPD patient, if you give them supplemental oxygen, you can actually increase hypercapnia secondary to VQ mismatch. That's the mechanism for supplemental oxygen increasing the CO2 in a COPD patient, because oxygen decreases hypoxic pulmonary vasoconstriction in areas of the lung that should be constricted because they're not being ventilated well. Peripheral chemoreceptors, the carotid body, responds to changes in P-little-a-O2, or partial pressure of oxygen. It's not responding to the saturation changes or content changes in oxygen, but P-little-a-O2. And when P-little-a-O2 goes down, the respiratory rate and tidal volume goes up. The next key word is ventilatory response at altitude. What happens when you go up, for example, to Denver, 1 mile high, or the top of Mount Everest, where the atmospheric pressure may be as low as in the 200, 220 range? Well, the first thing that happens is your minute ventilation goes up, both your respiratory rate and tidal volume, in an attempt to respond to the decreased P big AO2, or the alveolar oxygen that's present in your alveolus, because when you're at lower atmospheric pressure, according to the alveolar gas equation, when you calculate P big AO2, it is lower based upon FiO2 times atmospheric pressure, FiO2 being 21% times, instead of 760 millimeters of mercury at sea level, at the top of Mount Everest it may be 0.21 times 220. Therefore, you can see that P big AO2 drops dramatically as you go up in altitude. With a low PO2, P big AO2 in the lung, there is less transfer of oxygen into the arterial blood, so arterial blood P little AO2 goes down. The carotid body senses this low PaO2 and you begin to hyperventilate, which increases then P big AO2 in the alveolus, but as you hyperventilate, it decreases P little a CO2, the carbon dioxide in your blood, and you become alkalotic. Your body responds to this alkalosis by dumping bicarbonate from the kidney, and taking acetylzolamide or Diamox is a way to accelerate this process as you attempt to acclimate to altitude. So one of the ways to reduce acute mountain sickness is to take prophylactic Diamox, which inhibits carbonic anhydrase, helps you start dumping bicarbonate in your urine, and allows you to continue to hyperventilate. It acidifies your blood, allows you to continue to hyperventilate, shift your P50 right, increases your PaO2, and all good things for attempting to respond when you're up at altitude with low PaO2 in your alveolus. Decreased P big AO2 in your alveolus also results in hypoxic pulmonary vasoconstriction, or constriction of the blood vessels that are around that alveolus with low oxygen in it. Pulmonary hypertension can ensue, and high altitude pulmonary edema can result from this low oxygen at high altitude. You can also get high altitude cerebral edema, which is called HACE, as opposed to the high altitude pulmonary edema, which was called HAPE. If you get a headache and vomiting and confusion at high altitude, you need to get down very rapidly. Descent, dexamethasone occasionally can be used and is somewhat helpful. Supplemental oxygen, and even putting someone in a pressure bag to raise that atmospheric pressure back up towards normal as treatments. CO2 response curve is the next keyword. In the graphic on the far right is shown on the y-axis alveolar ventilation in liters per minute, and on the x-axis P little a CO2, or partial pressure of carbon dioxide. And if we look at the awake normal graph here, you can see that as CO2 goes up, alveolar ventilation goes up, and that CO2 ventilatory response curve is linear between about 20 to 80 millimeters of mercury. Decreased CO2 response curve occurs when a patient is older, when they're asleep, when they're anesthetized, and that's a shift of it to the right. Now the curve can be shifted not only to the right, less responsive to elevations in CO2, but it can the slope itself can be depressed when you have inhaled anesthetics and opioids combined, and that is the graphic on the far right showing narcotics and deep anesthesia, which has this shifted to the right CO2 response curve and depressed slope such that the CO2 can go up and you're not going to ventilate as much as you should if you were not exposed to opioids or inhaled anesthetics. Apneic threshold is increased by inhaled anesthetics and opioids. Alveolar ventilation CO2 relationship in hypoxia is referring to the concept that the responses of ventilation to increases in arterial PCO2 are made even more in the presence of simultaneous hypoxemia. So if a patient's CO2 goes up, you should hyperventilate. If the CO2 goes up and the patient's also hypoxic at the same time, they will hyperventilate even more than they would if they didn't have the simultaneous hypoxemia. The next keyword is a relationship of alveolar ventilation to arterial CO2. And a gap in knowledge on the entrance exam was that as minute ventilation increases linearly in a mechanically ventilated patient, PCO2 decreases asymptotically with a more rapid decline initially. Now that is a bunch of words basically stating what is shown graphically on the far right. On the y-axis is P little a CO2, arterial CO2, and on the x-axis is alveolar ventilation. And you can see that as alveolar ventilation decreases for example, from about 10 liters per minute down to 5 liters per minute, down closer to 0, that PCO2 in the blood builds up. That just makes sense. Less ventilation, less removal of CO2, the CO2 in the blood rises. But this relationship is interesting because you can see that if you are down at about 5 liter minute ventilation, or 4 liters or 3 liters, and the CO2, let's say in the blood, is like 50. Example would be a patient in the recovery room who has received opioids recently. Their CO2 is at 50 and they're breathing at pretty low minute ventilations, 3 or 4 liters per minute. Even just a small dose more of opioid or sedative can decrease the minute ventilation even just a little bit, and the CO2 rises dramatically. So a small dose of opioid can be dangerous to a hypercapnic patient. Arterial hypercapnia is either, by definition, not enough ventilation, or not getting rid of the CO2, or too much of the total ventilation ending up as dead space, going to a place that's not contributing to removal of CO2. The next key word is hypoxic pulmonary vasoconstriction, or HPV. When the P big AO2 decreases in an alveolar segment or in the whole lung, the pulmonary artery supplying vasoconstricts in an attempt to shunt blood to better oxygenated alveoli. And on the far right is shown graphically when the one alveolus is hypoxic, the blood vessels that are supplying it constrict and shunt blood away to the alveolar units that have adequate oxygen in them. On the graphic on the far right shows what happens if all the alveoli are hypoxic inside, P big AO2 is low, all the blood vessels constrict, and that would be an example of someone at high altitude breathing very low oxygen, and they can get pulmonary hypertension. So hypoxic pulmonary vasoconstriction is a mechanism to reduce shunt. Clinically, when we do one lung ventilation, the lung that's not being ventilated constricts, the blood vessels going past those alveoli and shunt blood to the lung that is being ventilated. Clinically, also pulmonary hypertension can ensue with hypoxic conditions when at altitude. When you have global hypoxic, both lungs low, P big AO2, and you can have right heart failure. And then a key word from 2019, again in purple here, is the things that inhibit this hypoxic pulmonary vasoconstriction. Our inhaled anesthetics do that to some extent. Our IV anesthetics have very little effect on HPV. So propofol, etomidate, opioids, benzodiazepines, little effect on HPV, while inhaled anesthetics inhibit it. Systemic vasodilators like nitroglycerin, nitroprusside, even ACE inhibitors, and other drugs that vasodilate can decrease HPV. That is, they could vasodilate these constricted blood vessels that should be constricted next to an alveolus that doesn't have much oxygen in it, and can decrease PaO2. And in fact, if you start a nitroglycerin infusion in someone and their PaO2 drops, this may be the mechanism of why their PaO2 dropped. You've blocked hypoxic pulmonary vasoconstriction and reduced normal shunt. Hypocapnia, hypothermia, changes in pH, calcium channel blockers, lots of PEEP, things that constrict blood vessels also can change the set point of HPV and negatively affect it. The last keyword for part 1 here is lungs and their metabolic functions. The lungs obviously exchange gases, CO2 and oxygen, but they also have metabolic functions. One, the activation of angiotensin 1 to angiotensin 2. ACE inhibitors block this. They also inactivate many vasoactive substances. An example of this is serotonin. Someone with a carcinoid tumor secreting serotonin, the lung will remove most of that serotonin before it gets to the left side of the body. So the right side of the heart is exposed to these high levels of serotonin when someone has a carcinoid tumor, and the tricuspid valve and the pulmonic valve can often be damaged by these high levels of serotonin. Tricuspid regurgitation and tricuspid stenosis, characteristically cardiac valvular lesions associated with high levels of serotonin in a patient with carcinoid tumor. Normally the lung inactivates serotonin as it passes through. Little effect on epinephrine. The lung also manufactures surfactant. It removes prostaglandins. It lyses clots that can occur in the pulmonary vessels. So the lung is not just exchanging gases, but has a metabolic function. This ends part 1 of a 5-part series on the keywords of respiratory and thoracic topics, and I hope you have a great day.